Well, good morning. Thank you for staying for the entire meeting. It's exciting to see so many people on the last day of a meeting. I'm Don Hayes.
Ming-Yao Liu.
So we're co-chairing a session here at NACFC. It's the Transplantation, Current Outcomes, Readiness, and Education of Patients and Future Directions. So I figured I would read what we're trying to accomplish as well as the objectives here. So hopefully you guys will assess that we have accomplished those. But we describe this as innovative. So hopefully you guys will agree that it's an innovative session that will provide some presentations on readiness assessment and education of patients for transplantation while addressing key post-transplant outcomes, while we also discuss potential future management approaches to transplant recipients. We're expanding not only from education research to clinical research as well as translational research. So it's kind of an exciting session. Our objectives are to explore current trends in transplant outcomes for people with CF, discuss approaches to readiness and education of transplant for people with CF, as well as to examine future approaches to clinical management and transplant recipients. And we're expanding peds and adult today, so this is perfect for the NACFC. So we might as well just go ahead and get started. I'll introduce our first presenter. This is the illustrious Dr. Kathleen Ramos. She's a wonderful, lovely person from the University of Washington. Well, some people call it, say, UW, but I'm trained at the other UW at the University of Wisconsin. So I've been having some fun with some of the people from the two UWs and which one is truly the UW. So. And Dr. Ramos is speaking on Lung Transplant Ready, pilot randomized clinical trial of a self-directed patient-facing lung transplant education website.
Thank you very much for the introduction. And I am presenting today on behalf of many co-investigators and collaborators. I don't really have any disclosures, but I do receive grant funding from the CF Foundation, the NIH, and I got an honorarium for speaking in a forum with Vertex. I'm actually going to start out with the thank you slide because there are so many people who were tremendously helpful in getting the patients recruited for this pilot RCT, and I don't want to leave it to the very end, and also to the CFF and CFF Community Voice, where we also recruited participants, the Take on Transplant study group with more than 15 CF centers, the people with CF and their caregivers who shaped Take on Transplant, and also the fantastic research coordinators, including Lauren Bartlett, who did so much work for this. So there is a major question in the CF community about the impact of ETI, or Elex-Tez-Iva, on the timing of referral for lung transplant, and there's been a dramatic reduction in the number of lung transplants for CF. It's likely that survival with low lung function will be prolonged on ETI. The median survival after an FEV1 less than 30% of predicted may exceed 6.5 years. And the psychological impact, including anxiety, depression, of lung transplant discussions and/or referral is unknown. For people with an FEV1 that remains less than 40% of predicted, markers of increased disease severity and the patient's reported satisfaction with their quality of life will need to be considered when we think about the timing of referral, and it may become more of a values-based decision with respect to when the patient and provider agree that it's time to refer. And there's going to be disadvantaged access to lung transplant as it exists now for patients in these disadvantaged groups. Ones with people with lower socioeconomic status, we use Medicaid insurance a lot of the time as a proxy for that, people with non-white race or Hispanic ethnicity. So shared decision-making is an evidence-based approach to increasing the knowledge, confidence in decisions, and patient involvement in their medical decisions. It leads to more accurate expectations about outcomes, and it can lead to decisions that are more consistent with personal preferences. Decision support can be brief enough to be used by the clinician and patient together in an office visit, or it can be more extensive and designed to be used by the patient before or after a clinic visit. And our data suggest that patients are interested in this type of engagement around lung transplant prior to when a referral is needed. So Take on Transplant is a CF-specific lung transplant education website that we co-produced with members of the CF community. We did continual iterations based on feedback and testing, and the usability and preliminary efficacy testing with pre-transplant patients with CF, both from the CFF Community Voice and multiple CF centers, and more than 100 CF patients have used Take on Transplant in one form or another. So I'll just explain Take on Transplant really briefly. It has 4 main components on the site. The first is My CF Stage, which is an assessment of disease severity and exposure to transplant. And so participants enter relevant data about their disease severity, their CF therapies, prior discussions about lung transplant, and then they get personalized content that's recommended based on their responses to that survey. That content includes CF stories, resource library, and frequently asked questions recommendations. And the CF stories have real patient stories from people with CF who've gone through lung transplant, the lung transplant recipients, individuals on ETI who delayed transplant or decided not to undergo transplant, and then caregivers of people with CF. We also have a resource library that has CF-specific medical information about lung transplant, and then these FAQs are common questions and answers about transplant. And all of the content is really in the patient's own words, but we've edited it to make sure that it is medically accurate and also consistent with what the meaning the patient was trying to convey is. And so we really worked with patients to get the tone correct. So the Lung Transplant Ready CF pilot randomized clinical trial includes lung transplant resources for education and decision-making for your CF. We compared Take on Transplant to UNOS.org, which we used as an attention control in a 4-week pilot RCT with 50 participants to determine the effect on preparedness for transplant discussions. We had collaborators at external CF centers who used PortCF to identify eligible participants with an FEV1 less than 50% of predicted within our population of interest. We were really trying to engage patients who had Medicaid insurance, non-white race, Hispanic ethnicity, and a high school education or less. And we call these communities of concern. We initially were calling them a vulnerable population, but we got feedback from some CF community members that people don't like to be called vulnerable. And so we changed the language to communities of concern. And so the external CF centers were not engaged in research. They actually just advertised a survey on our behalf that allowed the respondents to opt in for additional research, which was the pilot RCT. And we called them and explained it, and we were fortunate to enroll them. So this is the study schema for our pilot RCT to evaluate the effect of Take on Transplant. And so we screened patients to ensure that they had a CF diagnosis, an FEV1 less than 50% of predicted, and an age greater than or equal to 18 years through the PortCF registry. And they were randomized at baseline to either Take on Transplant or the UNOS website. At that first visit, V1, it was baseline before they saw either of the websites. We did multiple surveys, and I'll get to those in a moment. People had 2 weeks of access to the site to which they were randomized. Then they did their 2-week surveys at visit 2, and after their surveys were done, they rolled over to have access to the other arm of the study. To avoid the expectation of benefit from Take on Transplant, we actually told the patients that it was a study of 2 different types of transplant education because we didn't want to prep them for wanting to have benefit from Take on Transplant versus UNOS. So when they rolled over to the second part of the study, most patients switched to the other website and didn't really stick to their original randomized arm. So they wanted to see both websites, basically. We had continuous collection of website usage data throughout the study, and we focused on enrolling people who are disadvantaged to access to lung transplant. So we had 2 co-primary outcomes. The first was the feasibility of completing the 2-week study visit, and our hypothesis was we can do this, 90% will complete the visits, and we will recruit at least a third, 50% from communities of concern. And the reason we were putting feasibility first is because we did all of our study visits remotely. We did it through Zoom, and we were really trying to get this population that's hard to reach into our study. And so feasibility was our primary outcome. And then our second co-primary outcome was the website's effect on preparedness at 2 weeks, preparedness for lung transplant discussions. And our hypothesis was that take on transplant will lead to PrEP-DM scores, preparation for decision-making scale, that are higher than those associated with UNOS. And the questions in the PrEP-DM are shown here, and each question is rated on a 1 to 5 Likert scale. And it asks, did this educational material help you recognize that a decision needs to be made, prepare you to make a better decision, help you think about the pros and cons of each option, help you think about which pros and cons are most important to you, and help you know that the decision depends on what matters most to you, help organize your own thoughts about the decision, help you think about how involved you want to be in this decision, help you identify questions you want to ask your doctor, prepare you to talk to your doctor about what matters most to you, and prepare you for a follow-up visit with your doctor. I go through those questions because it's really important to understand what metric are we trying to move. We're trying to get people to really understand what matters most to them and identify the questions they want to talk about with their CF doctor with respect to lung transplant. And so we're comparing the PrEP-DM for take on transplant compared to UNOS. So other assessments are shown here, and these surveys assessed demographics, health literacy and numeracy, and socioeconomic status, in addition to efficacy measures and psychological measures. And we tracked activity within the research website using web analytics. And participants were asked to spend 2 hours on the website in the first 2 weeks, and we have granular data for their website usage for both study arms. So the survey was advertised at 15 external CF centers, and we received 92 responses to our survey. 60 patients opted into being contacted, but 10 were excluded because either they had participated in prior testing of earlier versions of Take on Transplant, or they self-reported an FEV1 that was above 50% of predicted. And so we approached 16 patients from the University of Washington, or UW, as well as the 50 eligible patients from the external CF centers. And we consented 52 patients, and 63% of them were in communities of concern. 2 people were lost to follow-up prior to their first study visit, and 50 participants completed all of their study visits up to 4 weeks, and 66% of those patients were in communities of concern. So we had a 4% attrition rate going from 52 to 50, and not anyone who'd actually come to a study visit. So the characteristics of the enrolled participants are shown here, and it's important to note that while we really did try to focus on people who were non-white or of Hispanic ethnicity, we didn't reach our bar there. We really want to enroll more people with Hispanic ethnicity, but this material was not available in Spanish yet, and so that did limit some of the recruitment. So our primary analyses are shown here. So feasibility. We had a 4% attrition rate, as I mentioned, both lost before our first study visit, and we had greater than 60% from the communities of concern. So this is feasible. We can enroll people in studies about lung transplant despite the availability of ETI. And the 2-week PrEP-DM scale was significantly higher in Take on Transplant compared to UNOS, and you can see, you can see at the bottom that the UNOS PrEP-DM was 57 and the Take on Transplant PrEP-DM was 71, and with only 50 patients, it was already statistically significant. We looked at the 4-week results for comparing the 2-week prep DM and the 4-week prep DM in both of the arms. And so, as you'll remember, at 2 weeks, the pilot RCT participants completed the prep DM for the website to which they were randomized, either Take on Transplant or UNOS. And after the 2-week study visit, participants gained access to both websites. At 4 weeks, all the participants completed the PrEP DM scale, but only for Take on Transplant. And so among participants who were randomized to Take on Transplant, the 2-week PrEP DM was 71 and the 4-week PrEP DM was 72. And among participants randomized to UNOS, the 2-week PrEP DM for UNOS was 57 and the 4-week PrEP DM for Take on Transplant was 77. And so while the Take on Transplant arm had lower usage of Take on Transplant in the second 2 weeks, they went to a median of 22 minutes in the second 2 weeks, down from a median of 130 minutes in the first 2 weeks, there appeared to be no association between this reduced usage in the second 2 weeks and the PrEP DM scores at 4 weeks, which stayed comparable to their 2-week scores on the PrEP DM. And the UNOS arm had similar or higher PrEP DM scores at 4 weeks as the Take on Transplant did back at 2 weeks. And that shows a consistent effect of 2 weeks of access to Take on Transplant. So it looks like, at least for a couple of weeks without a lot of exposure to Take on Transplant, people still felt like it was helpful to prepare them for their conversations with their doctor. We also looked at lung transplant knowledge. We have an investigator-designed lung transplant knowledge survey, and lung transplant knowledge was higher at 2 weeks in the Take on Transplant arm, but this result did not reach statistical significance. And the scores are down at the bottom for all of these graphs that I'm showing you. The decisional conflict scale results are shown here, and decisional conflict was lower in the at 2 weeks in the Take on Transplant arm, but again, it didn't reach statistical significance. The PHQ-9 decreased more at 2 weeks in the UNOS arm, but neither arm actually had a statistically significant change in PHQ-9 score. You can see at the bottom that the mean score at baseline for UNOS was a 5.4 on the PHQ-9, and for Take on Transplant, it was slightly higher at 6.1. At 2 weeks, the scores were 4.8 and 5.6, and so there was a slight decrease in the PHQ-9, but not really changed. And we were concerned that with the exposure to the lung transplant conversations, having them look at content about transplant, they might get more depressed, they might get more anxious. And that's what we were looking for, not necessarily a benefit for their depression, but making sure we didn't make it worse. And then for GAD-7, the score actually decreased significantly at 2 weeks in the Take on Transplant arm. It went down from a 5.6 to a 4.6, and the decrease of 1 was statistically significant. And the UNOS arm went down by just under 1 point on the GAD-7 as well. But we were really looking for harm here and seeing whether or not the GAD-7 increased over the course of the study. So our next steps, we're going to evaluate the broader markers of diversity in our sample, looking at health literacy, digital literacy, geographic representation, and explore the secondary outcomes. Also do some sensitivity analyses where we look just at the communities of concern or by gender, men versus women. Do they use the website differently? Do they have different outcomes? We'll also analyze the qualitative data. We have interviews from baseline, 2 weeks and 4 weeks for all of the participants in this pilot RCT, and we're planning to continue to improve Take on Transplant and understand the diverse perspectives about lung transplant education. And we're planning a larger multi-center RCT of Take on Transplant that's focused on disadvantaged populations, really trying to increase the number of people who are non-white and of Hispanic ethnicity that participate in the study. And then we also plan to reconnect with people who were involved in the development of Take on Transplant to get their feedback and share the results, because that's a really nice thing to close the loop and make sure they understand how the studies are going, but also to engage with them for updates or changes that they think would be appropriate. So in conclusion, enrollment at multiple sites allows for inclusion of more diverse patients in clinical research, but it does require collaboration and people being willing to put in the effort to help you recruit at their site. The personal narratives from CF lung transplant recipients and CF-specific information about transplant can improve CF patients' preparedness for lung transplant discussions, and a larger study will be required to assess the impacts of take-on transplant on additional outcomes of interest. Ongoing research may refine our approach to education about lung transplant for CF in the era of highly effective modulator treatments. Thank you.
Thank you. She's helping guide me up here. She's schooled at this. So before questions come from the audience, and we'll check if you want to check if we have any already posted, if I can get the thing to work. A couple of questions.
Okay.
Tremendous work. This looks like it could move the needle better for those communities of concern, and I really like that language. It's beautiful language. Is there a thought about looking at geographical disadvantages, meaning I primarily care for children, but some adults, and some of the adults may come from areas, mainly around our areas of the country in Appalachia. They may be geographically limited to access. Or is that a part or something that could be added to this as well, or have you thought about it?
Yeah, I didn't mention it during the talk, but one of the hard things is that people need to have consistent internet access, and we thought that people might need devices, phone, tablet, something along those lines to be able to participate, but it turned out that it wasn't the devices they needed. They really need data. And so during the pilot RCT, we started to offer mobile hotspots and prepaid data to participants, and that helped with 3 out of the 52 people who were enrolled, who were recruited and agreed to participate. And I suspect that because we used an online survey to recruit patients into the pilot RCT, we probably weeded out some people who didn't have internet or technology savvy. But in the full RCT, we were planning to approach people in person, in clinic, or by phone. We can recruit people as well. And so I think that the data issue is going to be a big one. And I think the fact that you can do this remotely from your home, wherever you are. Yeah. I think that helps overcome the geographic issues. It's just the internet is the problem, and so we can help with during the RCT, but the infrastructure bill and other things to change the access to people who live remotely and live in poor communities is obviously important.
One more question for me before I go to the audience questions. I care for children. As you know, there's changes thanks to high efficient modulators happening in the CF population requiring transplant, especially in kids and especially in the younger adults. Unfortunately, that benefit hasn't hit communities of concern in children. Are you thinking about adding pediatric patients and focusing this on children as well as adults? Because it seems to be more adult focused right now.
Yeah, that's a great question. It is adult focused right now since so few 18-year-olds even have advanced lung disease, less than 2% of 18-year-olds. But I think that pediatric and adolescent parents and caregivers could get a lot out of the website anyway, because it's CF-specific information about barriers to transplant, outcomes after transplant, and I think it's applicable. We just need to add a few pediatric transplant recipient stories.
Gotcha. Okay.
I think that it wouldn't be a stretch to expand it.
We have an audience question. Thank you. And we appreciate any audience questions that may come. This is from Dr. Corey Wynn in the audience. Just to let you know and give you credit for coming up with a question. He's one of our fellows, by the way.
It's biased.
Thank you for participating.
Yes. And so this is not a pediatric focused question. Is there a plan to compare PrEP DM results to the medical team's perception of patient readiness? That's a great question, Dr. Nguyen.
That is a great question. So because we recruited from all these wonderful people, we didn't have access to medical records or clinic visits, and we didn't really interact with the physicians taking care of the patients. But in the full RCT that will be moving forward in 2023, we will have access to both the patients and the physicians and the medical record, and we plan to survey the physicians immediately after a clinic visit and ask them about their satisfaction with the conversation about whether it happened, whether there was a conversation about transplant, how satisfied they were, rate the knowledge of the participant, and also ask the patient about their experience during the clinic visit as well. And so there will be a clinical encounter included in the full RCT. This was a pilot just to see, is it feasible to do this kind of research? And then in the full RCT, we're definitely going to get into the physician perspective too.
Oh, great. Thank you very much.
Thank you.
Thank you. Tremendous talk. All righty. Our next speaker will be Emily Scala. She's I think that's the order that I see here. Who will be speaking on bronchoalveolar lavage proteome identifies pathways of disease that segregate lung transplant recipients with versus without bronchiolitis obliterans syndrome, which is the culprit that leads to most morbidity in the late transplant period. Now, Emily is a tremendously talented young research assistant in the lab of Dr. Asim Zaidi at Cincinnati Children's, so all difficult questions should be directed to Dr. Zaidi today.
What he said, yeah, what he said.
Let me figure this out.
I think just have to hit start.
It's right here. Oh, you're right. She's teaching me. It's a generational thing.
Hello, I'm Emily. I'm a research assistant in the Ziadi Lab in the Division of Bone Marrow Transplantation at Cincinnati Children's Hospital, and I would like to thank the organizers for inviting me to present our work today. Dr. Ziadi, Dr. Hayes, and Mrs. Scala are inventors on a patent related to this presentation. First, a little background. Lung transplantation is a treatment option for many end-stage lung diseases, including CF. According to the International Society of Heart and Lung Transplantation Patient Registry from 2017, obliterative bronchiolitis and bronchiolitis obliterans syndrome remains one of the most important post-transplant complications, affecting approximately 10% of patients each year, especially in the first 4 years after transplant. Now that I've given you some background, let me tell you about our premise. We know that there are differences in lung transplant recipients that develop BOS, and we know what BOS looks like clinically. So we thought about looking at a proteomic approach. We hypothesized that determining the differences in patients with BOS versus those without may identify pathways that associate with BOS. How we did this was by using available samples in collaboration with Dr. Sharma, which included adult bowel samples from lung transplant recipients with BOS and without BOS. The cohorts were well matched for age, sex, and FVC, with mostly males averaging with the age of 60. And the best achievable matching was used for indication of transplant in FEV1, and the majority fall in the mild BOS category with grade 1. Although we don't have CF included in our cohorts here for indication for lung transplant, we think that it will extend to CF. And I have some exciting data at the end of the presentation about relating with an example of CF patient. Now that I've told you about our hypothesis and our premise, I'm going to tell you about how we went about running this study. First, whole bowel protein was precipitated with acetone, resolubilized, and fractionated with STS gel electrophoresis. An in-gel digestion was performed, and tryptic peptides were extracted. We used a liquid chromatography, tandem mass spectrometry, based label-free quantitation. Spectra were searched against a human FASTA database using Proteome Discoverer software, and differentially expressed protein isoforms were identified using a heteroscedastic student's t-test. Our standard cutoff analysis was without a decoy, and our higher stringency analysis contained a reverse database decoy and percolator. Then Metacore pathway analysis software was used. We find it important to use a standard and a higher stringency cutoff. With the standard cutoff, you get a big picture of what's going on. And with the higher stringency cutoff, it's more precise, but it definitely limits your data set. So those were our methods, and here are some of the differences we discovered. First, I'm going to give you a zoomed out view of some different processes that were revealed in our standard cutoff analysis. We see associations with development and proliferation, DNA repair, immune response and inflammation, viral transcription, cell motility, transport, remodeling, and cell adhesion. Now, I'm going to show you an example of how our network analysis software connected proteins that are associated with these processes in a network. This is an example of one network from our standard cutoff build of networks. And running this analysis, it creates 30 different networks, all with a p-value less than 0.03. The red circle by the protein indicates that this protein is upregulated in patients with BOS, and the blue circles indicate that the proteins are downregulated in patients with BOS. Now I'm going to go over a few proteins in this network. It's centered around the GATA group of proteins, which are transcription factors involved in cell differentiation in the immune system. PI3K class II proteins play a role in cell proliferation, cell migration, and cell survival. And KIAA 1914 plays a role in the cell cycle and inflammatory responses. I chose to show this specific network because it's consistent with what we know about lung transplant injury and BOS. We know that viral transcription is a trigger for BOS, and we know that followed by that, you get inflammation, cell adhesion, and structural remodeling. That was our standard cutoff, and now I'm going to show you the zoomed out view again of our stringent data analysis. We see associations with remodeling and cell adhesion, wound healing and coagulation, development and proliferation, and protein folding. Now I'm going to show you an example of a network with these processes. This is an example of one network from our stringent cutoff analysis. And like I said before, the stringent analysis limits our data set. So this one created 5 different networks, all with p-values less than 0.002. This network is centered around tissue kallikreins, which are involved in proteolysis, cell adhesion, differentiation, and protein folding. And C1 inhibitor is involved in inflammation, the complement pathway, and blood coagulation. And with C1 inhibitor being down, it means that complement is up. I chose this specific network because of the importance of wound healing and the complement pathway. Another way to analyze the data is by looking at disease associations. Our proteomic data associates with these specific diseases, Both cutoffs are consistent with pathways involved in connective tissue diseases and autoimmune diseases. In addition to these, our stringent cutoff analysis is consistent with joint diseases and wounds and injuries. Connective tissue diseases are consistent with rejection of new tissue grafts in lung transplant patients. In autoimmune diseases like rheumatoid arthritis, the immune system attacks joints, causing inflammation similar to what happens in graft rejection. Now that we've gone through some disease associations, I'm going to discuss our gene ontology analysis, which tells us which physiological processes associates with the data. Our standard cutoff go process analysis reveals associations with complement activation, viral replication in response to virus, membrane protein targeting, and negative regulation of response to reactive oxygen species. Those were from our standard analysis, and here's what we got for our stringent cutoff analysis. Continued associations with the complement pathway and new associations with platelet degranulation and antigenic inflammatory response. Now, in conclusion, the data suggests a host's response to virus and microbes, complement activation, and antigen presentation are features of disease in lung transplant recipients with BOS. And this is great to know because now we know which therapies we can use to target those processes. Furthermore, our proteomic approach may offer an opportunity for personalized diagnosis of BOS in lung transplant recipients. And now I'm going to show you an example of what it's like to do an N-of-1 study. So in this analysis that I just showed, we did 2 separate cohorts and compared the differences with each other. What we're starting to do is to work with one specific patient and look at the proteomics longitudinally to detect differences in the samples. Here is our analysis of our N-of-1 analysis in a patient with CF. The proteomic evaluation of the blood sample revealed an undiagnosed elevation of complement activation contributing to uncontrolled pulmonary inflammation. She was pretty sick with complications after her transplant. Her lungs were clear at baseline, and during her illness, you can see her lungs are inflamed. And using a proteomic-informed therapy, her left lung has cleared the inflammation 24 hours after therapy was administered. And I have to say, it's pretty cool that something that we're doing in the lab can be translated to something going on in the clinic with like real life situations. Pretty exciting stuff. And now I'm going to point out some limitations of our study. Limitations of the study include using a small cohort of samples from a single center, and that the MS proteomics employed here are semi-quantitative. In the future, we plan to expand our study population to pediatrics and recipients with different indications for lung transplant, including CF. I'd like to thank Dr. Ziadi, Hayes, and Sharma for the opportunity to work on this project, the lab, especially Matthew Seifert, Dr. Stella Davies, and the CCHMC Bone Marrow Transplant Program for all of the support, and the grant which supported this research. Thanks.
So I'll probably recuse myself from questions, but I can, if she can't answer one, I will try to answer it. And we have Dr. Ziadi in the audience, but we have a couple of audience questions. Thanks to Dr. Thomas Lynch, we appreciate that question. please speculate, reflect if you can. Might there be specific trends within the BOS group with BOS grade? Could this help inform course of pathology in earlier events?
That's a great question. Yes, no, I totally understand. I'm just not sure I exactly have the answer for you.
Yeah.
So we did not specify, I think we would have to have more, well, first, this was our first study analysis. So I think we would have to have more samples
Yeah.
within specific grades to be able to say whether or not they're different proteomically. But here we just didn't have that.
Yeah. The plan is, oh, go ahead, Dr. Ziotti.
Well, I was just going to say, we have looked at severity of disease in other conditions, for instance, severity of lung disease and CF, and we can actually correlate and have trajectories that line up with severity of disease and outcomes. So we suspect we'll be able to do that with a cross study, just need to do more steps.
We have another question. Dr. Kathleen Ramos asks, what was the proteomics-informed therapy? And she has a thanks with an exclamation point. Well, I'll defer that to Dr. Ziotti. If you want to disclose that, or
Dr. Hayes that actually administered the therapy.
I administered the therapy. So the thought is this is, well, do you want to answer or do you want me to answer?
Yeah, so it was a complement block. It's an antibody that you can use to block complement.
Yeah.
And Dr. Hayes, thankfully, we have a collaborator with him that, using along with clinical evidence, is willing to do what he can to help these
Yeah,
patients. He made a good choice.
Yeah, it was really cool. So if you want to know a little bit about the patient itself, it's actually a post-heart lung transplant recipient, post-lung with CF.
We'll put the pretty pictures back up.
Yeah, and so this was, I think, the second or third patient reported to the UNOS. We explored that, how many times that this had happened. But the young lady had CF, transplanted it as a young child, gravitated to us. I'd been caring for her for a few years, but she developed bronchiolitis obliterans syndrome. But during this time period, she developed Burkitt's lymphoma as a complication from PTLD, and due to that therapy, she ultimately ended up with diastolic heart failure. Her LV EDP was above 20, so we elected to do heart-lung rather than repeating a lung just due to the risk factors for primary graft dysfunction post, and her LV EDP was above 20. Makes me nervous. This is why I do heart casts in all my patients, and so left and right heart casts. But she was doing quite well, as you can look. Her baseline chest x-ray, she had some pleural scarring in the right parahilum from that surgery, but outside of that, she was functioning quite well, and she came in abruptly, acutely sick. And she had been in our study, and we'd been doing some analyses, and the wonderful group that I'm working with at Children's has really evolved into something. We've got a system now that's quite exciting, to be honest, because I can provide a sample to Dr. Zaidi and his wonderful team, and we can have information within it takes a couple days, and then, of course, he's the only person doing the bioinformatics analysis, but we knew complement activation it's an ongoing injury in what we're seeing. And I really didn't have an explanation for what was happening. It wasn't acute cellular rejection, but she came in, that was her presentation x-ray. She was intubated, as you can see on the next chest x-ray, and then we administered the therapy after we confirmed that this was active complement activation, and she started to improve pretty quickly within 24 hours of the drug. So. Yeah, the interesting thing is it's not compatible. So that's the exciting thing about the work, is that what we have currently in clinical practice isn't sufficient to diagnose what's going on. So hopefully we're going to change that needle as well. And so hopefully we're going to bring this to the CF Foundation, or CF population, hopefully with the CF Foundation help. We'll see. We would welcome that. We got a question up front.
This is a wonderful work. Congratulations.
Thank you.
It's a lot of work and very difficult to find for my pool. I have two questions. One is that I noticed most of the patient actually is adult patient, 64 years old. But
Yes.
these are from Children's Hospital. And then your patients are children.
We were exploring Because I'm new to the hospital. We're at Children's and new to the hospital. We had a biorepository that's been growing, but I needed a larger population. And so over the years, I've made good friends. Hopefully some of those are in the room. But a good friend of mine had recently relocated to Brigham and Women's. He and I had been collaborating. I'd actually been mentoring him from a distance, and so he wanted to participate. He begged us to send us samples, and we just decided to go ahead and do it with this. And it was basically a cohort that was simple and accessible for us. And so we decided to go ahead and explore it. And if we could find something in 65-year-old old white men, that would be exciting for us to explore. And I don't know if I should disclose this, Dr. Ziotti, but the findings are similar across even bone marrow transplant-associated bronchiolitis obliterans. So some of the findings that we found in that population are very similar, but I'll defer to him if he wants to share any more.
Well, we can talk about BNPVO offline, but Emily is also banking a number of pediatric samples right now. So
Yeah.
hopefully next year we can come back and tell you what it looks like in pediatric.
So we're expanding our population, and actually we think the CTOT pediatric studies samples are being sent to our institution, and we're going to further explore if we could use those from children. And we're exploring, we'll see whether the adult CTOT study will allow us to do the same analysis on the CF population in that group. So we submitted something to the CF Foundation for their RFA recently.
So my second question is that you started to report the pathogen immediately after you
Yeah.
gave the background. Did you have the number totally how many read or proteins you identified,
Oh.
and how many of them statistically significantly expressed?
That is an excellent question. I do not have that data on me right now, but I can,
How do you solve this?
Not thousands.
Not,
yeah.
We identified thousands, but there was differences in a couple of them.
yeah.
Yeah, hundreds.
And this was BAL fluid too, not necessarily serum. We'd like to do it or not serum or plasma.
Plasma.
Plasma, we prefer plasma. Yep, we
Yes.
prefer plasma sample.
But different though. Plasma is a systemic and
It-
it's a local.
Exactly, that's exactly. So this was a local sample, and that's why we wanted to really start there, but we'll see what comes out of it.
Competition.
Thank
Yeah.
you.
Great job. All righty. Moving on to the next speaker. The next one will be Dr. Alia Danny. She is a pediatric resident at the University of Texas Southwestern. She spent time with us at Cincinnati Children's as a research associate. She's going to be speaking on lung transplant wait list disparities for children with cystic fibrosis. Let's see, make sure I don't need Dr. Ramos back up here. Look at that. I'm somewhat trainable. Is it working? Oh, let's go back. It's working too well. There we go.
Thank you. Hi, everyone. Thank you for the organizers for giving me the chance to present our work on lung transplant waitlist disparities for children with cystic fibrosis. I'm very honored to be here. I have nothing to disclose. So the objectives of my talk today are to review the trends for lung transplant in children with cystic fibrosis, especially after the release of ETI, to address the trends on the wait list, especially with regards to racial disparities, and to discuss the reasons for those disparities. So as a background information, this is the annual number of pediatric lung transplants in the world. So as you can see, there are not so many pediatric lung transplants that are happening, but 50% of them are actually happening in North America. This is the distribution of pediatric patients undergoing transplant for cystic fibrosis versus other indications in the US. And as you can see, cystic fibrosis, which are the green bars, these are one of the main indications for lung transplant. And this is another representation of the same idea. So this is the absolute number of pediatric lung transplants for CF over the years. And as you can see, in 2019, there was a sudden drop in the number of pediatric lung transplants in the US. So, as an introduction to our current study, there are racial disparities seen both in adults and children. So in adults, for example, in lung transplants, white race had higher odds of lung allocation compared to all other races combined. And white race accounted for more than 80% of listed and transplanted patients. And the racial disparities also exist in lung transplant for children. For example, among those who received the lung transplant, the highest inpatient mortality rate was observed in Hispanics. This graph shows the frequency of white, non-Hispanic, and non-white cystic fibrosis pediatric patients undergoing transplant in the US. Again, the green bars are the CF patients who are non-white, and as you can see, they are a minority. So CF is predominantly a disease of Caucasians, and I've been taught that in medical school over and over again, but that's not the complete story. The post-lung transplant outcomes for children with cystic fibrosis listed for lung transplant are well studied. But what about the waitlist outcomes, especially when it comes to racial disparities? So the purpose of this study was to examine whether survival differences exist between white, non-Hispanic, and non-white children with cystic fibrosis who are listed for or underwent a lung transplant. So we used the United Network for Organ Sharing, UNOS registry, which includes all patients who were listed for or got a transplant in all organs. And we searched for children with cystic fibrosis who were aged less than 18 years, who were waitlisted for or who underwent lung transplant in the modern era, which spanned from January 1, 2000 to December 31st of 2021. Then we divided our patient cohort according to race and according to the race definition in the UNOS registry. So it included white, non-Hispanic, and non-white, and the non-white included Black, Hispanic, Asian, and all other races. We then used the chi-square and non-parametric median tests to compare categorical and continuous variables. And then we used the Kaplan-Meier curves with the log rank testing to compare survival on the waitlist and post-transplant survival. So from the UNOS registry, we were able to find 828 children with CF who were listed for lung transplant, of which 80% were white and 20% were non-white. There's no surprise there. And when we compared the two cohorts, we found that there is some differences, mainly in age and height, and then in the total days on the wait list and the GFR. So the non-white were actually younger, shorter, and had worse kidney function than the white patients at the time of listing. And the non-white spent less time on the wait list than the white patients. And this could mean spending less time because they actually reached transplant, or spending less time because they maybe died on the wait list. There was no significant difference in FEV1, FVC, diabetes, or LAS between the cohorts at the time of listing. So we explored the reasons for removal from the wait list between the two cohorts, and we divided those into negative outcomes, which included dying on the wait list or being removed because of deteriorating conditions, and positive outcomes, which included being transplanted or being removed from the wait list because of improving conditions. And there was a significant difference between the two groups when it comes to negative outcomes. So the non-white population had 1.5 times higher risk of dying on the wait list compared to the white population. And for those who like graphs, we did a survival analysis that emphasized the same idea. So compared to the white population, the non-white children with cystic fibrosis had significantly higher rate of death on the wait list or removal from it because of deteriorating conditions, as you can see here. We then picked the patients who actually got the transplant, and those included 58% of the total listed patients. And again, 80% of them were white and 20% were non-white. There was no difference in terms of demographics between the two groups when they reached the time of transplant. And then we looked at the post-transplant survival for those patients, and there was also no difference in the post-transplant survival between children with CF who were white versus non-white. So there's really no difference in the post-transplant survival, but there's something going on the wait list for these patients. So children with cystic fibrosis who are of a minority ethnicity or race are more likely to die on the wait list. but once they reach transplant, there's no difference between the two groups. The reasons for the disparity include, but are not limited to, having a worse disease progression. So we know that non-white patients have worse disease progression, they have higher mortality and morbidity. Social determinants of health of all sorts, socioeconomic, access to education, access to care, but mainly access to pediatric transplant centers, because so many children with cystic fibrosis are actually transplanted in adult centers, especially in the adolescent group. And then CFTR modulators, of course, that currently target mutations that are more common in the Caucasian population. And I actually found this great table from McGarry et al. That emphasized that. So looking at all CFTR modulators, the non-Hispanic white were significantly more eligible to the modulators compared to all other races. So there's a significant lung transplant waitlist disparity for the non-white children with cystic fibrosis that was identified. This is only preliminary data, but it's very interesting. So despite the advancements in the CFTR modulator therapy that are greatly reducing the need for lung transplant in white cystic fibrosis patients, we anticipate the need for lung transplant to continue in the non-white until specific discoveries can address the more common CFTR mutations. Further insight into the relationship between race or ethnicity and waitlist outcomes is needed to ensure equitable access to lung transplant among pediatric patients in the US. Our future work will include studying the ERAS effect based on when the CFTR modulators were approved, to examine the differences among children listed at adult versus pediatric lung transplant centers, and to develop a plan for mitigation of any possible biases against non-white that are increasing their mortality on the wait list. Thank you.
Thank you, wonderful talk. We have a question from the audience, one thus far. Please ask more. I keep on loving Dr. Kathleen Ramos. She has another question. Rather than grouping all non-white patients together, did you look at black patients separated and/or Hispanic patients? ? I understand the numbers may be too small. Great question.
Yeah, we actually did not separate the non-white into smaller categories, but yeah, I suspect the numbers to be too small too, especially when it comes to transplant and looking at the transplant outcomes. It's only 96 patients who were non-white, so dividing them further into smaller groups will be a very small number.
Unfortunately, we are limited by numbers. We'll go ahead with you, Dr. Luke. No, we have another audience question. Dr. Kapniak said, great job. We all agree with that. Also, non-white may actually be disadvantaged in ability to get listed for transplant. Could the shorter stature have been a factor?
So when it comes to, maybe, I don't know actually the answer to that question. So we didn't look at so there was a significant difference between the two groups, but we didn't, in the Cox model that I did, there was no significance for the height or any other variable actually when it comes to being listed or when it comes to post-transplant survival. But maybe we can explore that more and see if that's actually one of the differences.
You go ahead. We've got more audience questions rolling in.
Okay, I wanted to first congratulate you for the junior investigator abstract award.
Thank you.
Congratulations.
Thank you.
My question for your presentation is that I'm not a CF person, I'm a lung transplant researcher, so I do not know too much about CF. But I do know that the CF mutation different genotype. Would it be possible for the non-white, they share very different genetic backgrounds, so that contributed to this wait list and mortality?
Absolutely. So, yeah.
Did everybody hear the question?
Yeah.
Would you mind repeating?
So the question was that the white and the non-white basically have different phenotypes and whether that contributes to the increased waitlist mortality. And I think this is one of the theories that we have, that because the non-white have different mutations, the CFTR modulators that we now have do not target those mutations. And so this population is at a disadvantage because right now we don't have enough modulators that make them, we don't have, so the non-white are not eligible for the CFTR modulators that exist right now, especially ETI. So that's where the future work should be in terms of CF.
Important because if it's a genetic difference or the social status, right?
Yep.
So it will be treated in a very different method of strategy. So do you have similar study from adult patients to compare white and non-white in CF patients on weekends? I mean from literature. So you can compare with it.
I don't know one, but.
So you
but
did
maybe
a
not.
pediatric comparison.
Yeah,
Is anyone did an adult comparison between white and non-white?
I'll answer that for it. To my knowledge, I don't think anyone has explored racial differences on the wait list. It's often somewhat missed because I think most people are more worried about the post-transplant outcomes, but you're exactly right. It should probably be addressed if it's not been done.
Yeah, if that has not been done.
Unless you know something, Dr.
I think
Ramo.
that comparison could be very critical.
She may have, burning information behind it.
For adults that have been listed, non-white race is associated with
Yeah.
increased risk of dying.
Yeah.
and non-transplant.
In general, that's what I assume, but I don't know if anyone separated out race according to cystic fibrosis.
For CF patient,
I-
and.
They have,
And Carly Lair's paper that was published last year looked at multiple measures of socioeconomic position, including race, ethnicity, education level, et cetera. And every time you got an additional socioeconomic barrier, it increased your risk of dying
Okay.
without waitlisting.
Mhm.
But there was another paper that looked at the risk factors for dying on the wait list, and race is always.
yeah.
Yeah.
So we have all kinds of audience questions. Since you were so efficient with time, we'll keep on going. Dr. Singhal has asked, do you think changing LAS score in 2005 affected data?
Yeah, that's a great question. We didn't look at the ERAS effect yet.
Yeah.
So I believe that this is the next step, is to look at how different changes in the UNOS policies, but also the release of CFTR modulators changed the trends on the waitlist and the post-transplant trends. And we can use time or ERAS as a proxy for these changes. So that's the next step for this study.
Dr. Sagana asked, were you able to determine the percentage of people on the wait list who were on modulators? Are you able to see cause of death from the registry?
So the UNOS registry is very limited, actually, and we don't have data from the UNOS registry on patients who were treated with CFTR modulators. I believe that we need to go and dig in other registries. Maybe the FIZ registry has more information on that, or maybe going into a multi-institutional study where we can actually gather that information. So,
Dr. Ramos?
Yeah, there's a comment, I put a comment, you can
Oh.
actually, it's newly going to be available, the CFF patient registry merged with SRTR. The foundation is going to be accepting applications for that data set
Oh.
in the near term, next couple of months, it should be turning around, so you should ask for that.
yes, thank you.
Another question from Dr. Nguyen. Do you have a sense of why kidney function was worse, indicative of more antibiotic exposure?
That's a very clinical question, and I don't have the expertise to
Yeah.
answer that. Sorry.
Yeah. We don't have antibiotic history in the UNOS registry, but we do have estimations of renal function. So the two probably do correlate, but we have no way of proving it. Just the limitations of the data sets available. We have another question. People are really excited about this. Is there a correlation between race and patients requiring bridge to transplant, such as ECMO?
So ECMO, actually, I don't think I explored ECMO. I explored the ventilator use. Yeah, that probably should have been part of the chi-square and also the Cox model. Great question. Sorry, we didn't do that.
Here's another interesting question from Dr. Muse. Did you separate out blood type with regard to waitlist time?
No. We also don't have a lot of information on blood. So blood type is one of those variables in UNOS that always have a lot of missing information. So it wasn't used for the study or for the analysis that I did.
That's all the questions we have. And I don't know if everybody heard, but Dr. Liu made the comment. She was actually nominated for an award for this submission and presentation. So we were excited that she was a part of this session. So thank you very much. We appreciate you.
Thank you.
Okay, so let me introduce the next speaker. It's Dr. Norman Chaudhry, and the title of the presentation is Development of the Collaboration within the Advanced Lung Disease Meeting on Transplant Referral Process at Virginia Commonwealth University Adult CF Center.
Good morning, everyone. Thank you for having me here. And this, I'm a clinician, so this is kind of a clinical talk, and thank you to CF team members who submitted this and worked with me. We were part of the Learning and Leadership Collaborative of the CF Foundation over the last 5 years.
Yep, we'll take it. Anybody want to order lunch?
It does have my credit card and Apple Pay. So
Credit here at the
how do I
Oh.
forward?
You have to actually touch inside of it. There we go.
Okay. So I do not have any conflict of interest in relationship to this talk. So as you know, just to give you some demographic of state of Virginia, this is on the East Coast. We have about 4 CF centers. And, we are one of the first or second large CF center in state of Virginia. When we became part of this meeting and started this meeting, this was 2017. So this was before the CF Foundation guidelines were published. We were the first wave of lung transplant team members who were actually part of submission of input into the guidelines development at that time. So we recognized the need, along with this wave, to how to identify these patients that we call advanced lung disease, how we can stratify them based on their risk of transplantation, and how we can have them educated and have them referred. The big question clinically is, am I too early to refer them? Are they enough, educated to the enough point that they have the enough information to make that decision? Are we going to make their PHQ-9s worse and make them more anxious? So there are several of those clinical questions that were coming up at that time. And really, there was no such definition of advanced lung disease. And back then, the older guidelines were like FEV1 less than 30%, patient should be classified as advanced lung disease, and then basically should be considered for transplantation. It was mainly a physician decision. There was not really involvement of the team members, and more of the education was missing as well. So there was a big need at that time. So this is a work that we did over the last 5 years, and we were going to share some slides and give you some information about our experience. Our center back then was about 80 patients, and since then we have become about a center of 130 patients, and these are all adults patients. So we initially defined the advanced lung disease as people who were FEV1 less than 50% ever in their lifetime. So we put them together, and we said they will all meet this definition of this advanced lung disease, and they will be discussed in a collaborative meeting. And basically, since then, we have altered the definition to modify it. And the modified definition, as you know, the guidelines recommend typically about FEV1 less than 40%, especially if you have rapidly declining markers of advanced lung disease, like poor 6-minute walk test performance less than 400 meter. If you have the poor PaO2 ratio in your ABG or PCO2 or hypercapnia, where you have ventilatory failure, or on the echo evidence of higher mean pulmonary artery pressures or suspicion of pulmonary hypertension. But since we had that definition, we decided to stick with it and see how do we do. And as I'm going to share some of the data, you will see how the numbers went down over the last 5 years. And some of that were thought to be related to some of the advancements from the drug therapy that we have seen over time. I think all of us are familiar with Trikafta and the effects of Trikafta on the referral process. So the big point of this meeting idea was just like in similarity to the listing meeting that we have at the transplant centers. So we said, can we come together, put together a team of people, of multidisciplinary team members, social worker, nurse, dietitian, and then have about 3 patients that we can discuss each month and have the direct input of transplant center in that meeting. So this is pre-COVID. This is all something that we started virtually pre-COVID. So when the COVID hit, we were all very well equipped with the Zoom meeting and having all that session in a team. So we had been doing it about 2 years prior to that. So as we can see, based on this, we actually said if they had 2 PFTs, if one of the PFT was less than 50%, they will meet the definition of, especially if they are non-exacerbation free, not during an exacerbation, they would meet the definition of advanced lung disease. Then we said, who will be present in that meeting? So we decided, as I mentioned, as a physician, referral person, and I'm the only physician on the adult side currently for this center, but so it was easy for me. But we also had the person identify the referral in the transplant center who would be the physician on the transplant side. So we had about 4 options there. So in state of Virginia, based on the insurance, sometimes we require an in-state referral first, and then we have to go out of state if in-state transplant center decline it. So if I do not mention, we do not have a transplant in our center. So we had University of Virginia, which is about 50 minutes to our west or east. Something on our east, so up north is about Inova. I don't know, Whitney Brown here. So basically, we had some discussions with her. And also, we stretched out mainly with our Duke University because the collaborative was based with Laurie Snyder and John Reynolds and Duke University Transplant Program. We actually had a site visit back then in 2017, and that site visit generated that interest. Can we replicate that listing conference as an advanced lung disease pre-transplant referral meeting and have that discussion start way earlier, even before the patients are actually considered to be transplantable or really in emergent need of a transplant? So all these people were involved, and we had to discuss, okay, what are we going to discuss in this meeting? So we had to identify some markers of progression, and based on this, we said, if they have the frequency of exacerbations, and now we know the more the exacerbations you have, the more the chance of declining health you have, right? So especially along those FEV1. So if you're requiring 1 IVs, 2 IVs, we would highlight that. The patient is requiring 2 IVs in the past year or 6 months. And some of these were not part of the definite guidelines back then. Some of the things we were looking for as part of lung allocation score, like ABG markers, 6-minute walk, those specific indices, they were really lacking for clinicians to make that determination. It was a broad call for FEV1 less than 30%, send them to transplant. So it was kind of easy to say, but it was difficult to mention it to the patient, whether it's too soon, where they are in the transplant, what else kind of do they need for education or referral. So we also look for, are they using oxygen? Do they have need of nutrition or tube feeding? We review if they have comorbidities like diabetes, which actually can lead to renal failure. So some of the other, I think the previous speaker was talking about chronic kidney disease. We have people who have uncontrolled diabetes who ended up on dialysis pre-transplant. So something that we have to really screen very aggressively with albumin-urea and creatinine ratio, work on those blood pressures, and work on those glycemic control to make sure when the time comes they have good kidney function. We also look for their DEXA, vitamin D levels. We also look for their liver functions. And we put together a referral letter that has all those indices in for the transplant person. So how does it help? So I'm not a transplant physician, but I'm sure transplant physician will appreciate that, right? When they see these markers, they don't have to go back and forth 10 times. Go back to your physician and say, what was your kidney function? Why did Dr. Chaudhary send you here? And etc. So it can happen. We don't have same chart. We are about 2 hours up north. We are about 2 hours up south. We are about 4 hours at University of Pittsburgh for certain bugs like Burkholderia sinusopatia. So we know, like, we expand our horizons based on the indications, based on the clinical needs, and also who could help these patients more. especially if certain centers are going to be less willing or accepting the difficult bugs like back NTM disease or bad gram-negative resistant infections or multi-resistant infections, we continue to look up and involve these other centers. So we also look for other markers like if they have increased fatigue, their capacity to do work, changes with their anxiety, depression, and increased reliance on some of the other support members or allied members, as well as review their insurance and prepare their financial status beforehand. So they have all the education they need for a potential referral. It won't be a bombshell right at the last minute to say, okay, now you have to scramble. You are on ECMO, you are on a ventilator, you are on all these other last-ditch efforts to say, okay, what do we need to do? So the purpose here is identify these people each year, stratify them based on their FEV1, classify them. If they have less than 50%, they will be considered like milder, discuss them once a year. If they have less than 40%, they will be moderate, they would be about orange, and then less than 30% would be red, and they will be discussed every quarter. Person who will be orange will be discussed every 6 months. Person who will be about less than 50% will be discussed once a year at least. We also look for obstacles, substance abuse. We discuss if they have good social support and they are not doing any things that would prohibit a potential transplant process. We also discuss the contacts in our center and in the transplant center. We also educate them, what does this referral really means to you? Is it going to be a shorter referral for someone who's less than 50% versus someone who would be less than 30% with poor markers who would be there for a week? What their accommodation would be? So this is all the work that has happened in the last 5 years. We did not have these indices. We did not have these education markers. We did not have these capacity to have in-depth knowledge of the transplant workup as well as the transplant education that we developed. So we actually identified a folder, and we call this as an education folder, and we measured how many patients were going to be educated each year and year by year, and how many patients will be referred who have been educated as part of this process. So we discussed with them that typical transplant survival had been about along the lines of 10 to 12 years. It could improve quality of life, but it does have some stake at it that you will have to take lifelong immune suppression, and then you will have to follow with both centers for a while. You will have the CF center as your primary local center, and you will have your transplant center as your another center that will be very involved, at least for the first several years, for all your post-transplant workup and bronchoscopies and biopsies. So that will involve that they may need to have local accommodation, they would have the capacity to travel, they will have the education and informed decision right there. As part of this, we were less willing, as the palliative care guidelines were developed by Foundation, we were less willing to bring this topic up as clinicians. We were always in the fourth gear. This was like back then in 2017, there was no Trikafta. We were not going to give it up. I don't know. We were just like, you have to do this. There's no option for you to just not give up. I was like, you are a young person, you can do this, and why are you giving it up? Why the family wants to give up? And I think the mentality was kind of more towards, you need transplant, you should go for transplant. And there was less involvement of palliative care colleagues. But we appreciate the guidance from the Foundation since then as well. The guidelines for palliative care have been specified. So we have included that as part of our education in our education folder, that is an option for certain people who actually would benefit from palliative care discussion. So this is a very busy slide, but just to mention at the bottom here, I think if you focus, these are all the posters we have presented over the last 5 years. This is one of the 7 phases that we call. So we developed this meeting as part of the phase 1. We identified who will be participant, who will be referred, who will be educated. We also discussed like what resources we will share. So all team members put in together an education folder and involve some education material. We have this on an online form. We also have this on the actual physical form. We gave it to all the patients. We Also involved education along the site visit for Duke and involved their team members. And then team-to-team education happened, dietitian to dietitian, social worker to social worker, and physician was directly involved monthly for each meeting, each month. So some of this dashboard, just to give it to you, that I think we aim for, I don't know if you can read this in this poster here with the light, but we aim to identify and improve screening of advanced lung disease people who were identified with less than 50% FE1. Then we have some specific markers here. We wanted to stratify them every year. We wanted to make sure that they have received the education folder, they have been discussed in the meeting, and they have been referred to the transplant. So on the left bar here, this is about a 5-year Myers, and there are about 6 different Myers. So we identify about 45 patients out of 80, about 50% or so, who were advanced lung disease who ever had FE1 less than 50%. Over time, in 2020 or something, I think when I last looked at this, we had about 19 patients. So we were dropped down to about little less than 50% that had come after Trikafta and the revised definition. We also looked at the education similarly went down. We also looked at the discussions in the meeting kind of went down on some of these patients based on their interest. And then which is an improvement actually, which is a good thing. Also the referral process showed improvement, and like almost all the people that we discussed had been referred. And this is a 5-year process, so we were revisiting these patients repeatedly over time. And then patients who were identified had different demographics. So on the left, there are about a little bit more males than females. And these are the different centers we were referred. So Duke was the primary center. And then some of the other referrals were in ANOVA, UVA, and Pittsburgh. And different organs were involved in this referral process as well. So that's the other thing that we haven't been able to firmly identify, because we have some people there too with pancreatic transplant who could be part of this meeting. There are about 1 or 2 patients who have liver transplant, and then we tried, and kidney transplant. So we try to not miss them, because it is also an opportunity for us to continue to collaborate with transplant centers as part of this meeting in the post-transplant period to how to improve their care and standardize their care. And then on the leftmost, my years were really about different kind of patients over time. And sorry, it is pretty small to read, but I think this is what the nutshell was about this. So what kind of lessons did we learn? I think this slide really helps us out about our experience in the last several years. So we identified that stratification and earlier discussions helps with the meeting advanced lung disease. Advanced lung disease classification led to increased testing. So we did a lot of echoes, 6-minute walk tests, CT chest every year, oxygen evaluations, ABGs, VBGs, and a combination of sleep study. Patients who were classified as advanced were re-stratified to a lower category over time in our center. We also felt Trikafta changed the outlook for transplant and advanced lung disease at our center. Patients who were more than 30% were less willing to go and see the transplant center. Formal education techniques were used initially, but later on we fell off a little bit of giving everybody the folder because they were less interested in receiving the folder. There is provider and patient hesitancy regarding timing of referral. Advanced lung disease meeting held with communication and satisfaction among clinical team members. Advanced lung disease pre-transplant referral center meeting cannot fill in gap between surgery or transplant. Insurance concerns, social support, and patient acceptance could be some of the reasons for delay. And advanced lung disease discussion did not lead to more transplants in our center. This is some of the work that we want to carry on to identify how do we improve in the next phases of advanced lung disease post-transplant care. Because that's where the care, like some of these patients show up in the ER with abdominal pain, diarrhea, or etc., and I have not seen them for a year. And the transplant center was following them. So how do we standardize post-transplant care among some of these patients? So I think some of these sheets are going to help. We also have a poster. So thank you very much. I think I'm also at my time.
No, we got plenty of time. Tremendous talk, great work. I have a question. When you do find a challenge, mostly at our center, it's usually challenges regarding mental, emotional, behavioral health. Is there a center that will take the lead? Is that something that's done, together, or is it one center doing it, or the other one assists? Just a thought about what happens when you find a challenge to transplant.
I think that's a great point. So my go-to clinically is my psychiatrist as part of the CF mental health committee. And then they also have this mental health coordinator who was actually involved in this development of this. And now we do not have a coordinator, but have a long-term psychiatrist in the clinic once a month, and I can also reach out to them. So they have some involvement there. Other than that, we work with social worker to look at the barriers. I work on one-on-one with them and try to see how we can identify. We have a close-knit connections with these patients. I've been taking care of these patients for, at least 10 years, so they trust us a lot, and that helps somewhat. I have a patient who is DNR, and I have to respect his decision, even though he's doing much better on Trikafta, and he had a lot of struggles with psychological measures as well as with the substance abuse. He's not doing substance abuse anymore, and his depression scale is improved as well. Clinically, he's doing much better. So I think at some point he may reconsider his DNR decision.
Yeah.
And we also have this palliative care model that is so hard to implement to take that, but I think that's another important piece that we have to see. I think there was a grant out for an RFA, and maybe CF Foundation Alfaro can mention that how that has been going for other centers, or if other centers have experience. But one of my hope was really to see how they can help out with some of this communication as well.
It can be rewarding when you change that kind of outcome. I've been involved with a couple, so I can appreciate your passion. We do have an audience question, only one thus far. I'm sure people out there typing. Dr. Sagana asks, how does your center keep track of patients who are seen by a transplant center but deemed too healthy or had barriers to transplant? So this is more of a healthy question. What is the process to determine when to send them back to the referral center?
Yeah, so I think that's where the stratification is coming in. So exactly, the question is like if you are too healthy or deferred. So this is actually bringing up a good point, because I've meant to ask the CF registry. I don't know how many of us are involved in data entry, but I did that in the last 6 months myself when we did not have a coordinator. So it was hard to put in those people in the registry who are deferred. It says declined, refused, or etc. There's no deferred in there. So I think we should have a column in there as a button who have been reviewed and deferred now. So that will help us to do this from the registry aspects, but also clinically, that's the thing that we are trying to. So we try to stratify the patients once a year, or addition of a new patient if the new patient has moved into the center, or etc., or somebody has changed their FE1. Then we have the transplant center. I have his cell phone in most of their cell phones. So we can check with them to see how the communication can go along from there. We also have this referral letter that goes to them, and they have a letter that come back to us in Epic. So that's how this is going. And if we have, so the communication there is, previously we had faxes, and faxes were loose. We are not on the same chart. Epic is helping because we're now on the same chart, so we can see how the referral process is going. It is not ideal as much as I wish it to be, to see if they're more than 30%, and there is no such thing after so I take it back. So I have few patients who have been deferred. Actually, many of them have been deferred in those 16 patients now. So I am taking care of them myself, so I don't know, I think most of us will be doing the same, because I want to change and re-refer them back when they are going to decline. But I want to continue that discussion as part of the virtual advanced lung disease meeting with the transplant physician, that I did this 6-minute walk test. It's gone up from 400 to 600 meters. Patient is not on non-invasive ventilation anymore. There's no more hypercapnia. So I look on those clinical indices and mention to them, say, great job, keep it up. And I think that's reassuring for me as a clinician. They're reassuring for the team members. If they are here, I really appreciate. So they all are on the same page. So it's one word coming to everybody up front to the patient, and the patient is hearing one voice that, hey, I'm doing good.
Okay. Excellent. Well, thank you. I do have this, so lunch is on me at the market.
This should be a rule. Next speaker should
put the correct car on desk as well. So let me introduce our last speaker. The title of the presentation is a computed tomograph body composition and the clinical outcome following lung transplantation in cystic fibrosis. The speaker is Dr. Ann Generich from University of Washington.
I had a colleague at LSU in Louisiana who said, "You guys sound ridiculous when you say UW. Nobody knows what you're talking about." So I've been conditioned to say the University of Washington. So today I'd like to talk to you a little bit about computed tomography, body composition, and clinical outcomes following lung transplantations for patients with cystic fibrosis. I don't have any relevant commercial interest. I'm supported by the NHLBI, and the work that I'll present here was supported in part by the Cystic Fibrosis Foundation. So when we think about body composition, one of the things that immediately comes to mind is nutritional status, right? So the things we put in our body, how our body uses those components, help determine our muscle mass and fat mass and our bone mass. And nutritional status is really important in all patients with advanced lung disease, not just CF, but particularly so where malnutrition is very common. And it's been associated with worse prognosis in the pre-lung transplant population. And there are a lot of factors that contribute to malnutrition, right? Energy expenditure is a big one for people with chronic lung disease, the increased work of breathing, recurrent respiratory infections, and then you have issues with gut inflammation, pancreatic insufficiency, which contribute to malabsorption, and then poor appetite. So all of these factors come together to affect someone's nutritional status. And, we don't have great metrics sometimes for understanding somebody's nutritional status in the pre-transplant setting. And one of the metrics we do use is body mass index, which is just simply your weight in kilograms divided by the square of your height in meters. And just on its face, when you think about body composition and body mass index, there's a lot of missing information there, right? Your weight doesn't tell you a lot about all the other components of your body. And moreover, BMI itself has an inconsistent relationship with post-transplant outcomes, especially in people who are underweight, which is a common issue in patients with cystic fibrosis. So really it leaves much to be desired. If you think about body composition, you have adipose tissue, and then you have adipose tissue free mass, which is water, bone, skeletal muscle. And so if you think about these, just sort of the obvious responses, these things aren't the same. But we use BMI for a couple of reasons, probably primarily because it's so easy, right? I mean, it's so easy to check somebody's weight and height. These other measurements are harder to take. And there are a lot of different ways to look at muscle mass. You can use DEXA scanning, but in the past probably decade or so, there's been a lot of interest in using CT scans, so computed tomography to assess muscle mass. And there's a huge amount of literature in the oncology population related to using CT to assess muscle mass, but it's not been done as much so in lung transplant populations. Why does this matter? And I think it matters for many reasons. One, when you lose skeletal muscle mass and function, often that's called sarcopenia. Sarcopenia is a key component of the syndrome of frailty, wherein people accumulate physiologic deficits, and those deficits are associated with adverse events. Sarcopenia itself is linked to mortality in advanced lung disease and worse outcomes after transplantation. But the data that we have about post-transplant mortality in lung in patients related to sarcopenia is really limited in the cystic fibrosis population. So if you look at the existing data specifically in lung transplant, there are very few studies that even include more than a handful of CF patients. And the one that does have a sufficient number doesn't have disaggregated data, so everybody's lumped together. So you're talking about people with IPF and COPD, and these are obviously not the same patient populations. So including a measure of muscle mass in a pre-transplant risk assessment might give us a better idea of someone's post-transplant risk. And CT, of course, has been used in these other populations. It's also been used in other solid organ transplant populations like liver transplant. And so it sort of begged the question for us, how does this relate to outcomes in people with cystic fibrosis? So we wanted to know, is muscle mass measured by CT associated with post-transplant outcomes after transplantation for CF? And we hypothesized that not only would lower muscle mass be associated with poor pre-transplant pulmonary reserve, that just sort of intuitively, if you have sarcopenia, you may have a worse outcome. And that would be consistent with data in other populations, cancer patients, liver transplant patients. So we looked at patients at the University of Washington between May 1993 and December 2018. And in that period of time, there were 152 adults with CF who were transplanted. And of those, 93 had accessible CT scans of the chest within a year pre-transplant. And when I say accessible, I mean obviously we could get them. We didn't want to put people through additional scans just for this research project. The beauty of doing this for a lot of different populations is you can use scans that are already being done, so you don't have to give people an additional radiation risk. We chose a year within transplant because we didn't want scans that were done 2 or 3 years prior, right? They may not be reflective at all of someone's current muscle mass. So we cut off there, and for this population, the median days from scan to transplant was 122. So it's pretty close, relatively speaking. We did exclude people with multi-organ transplant or retransplant just because it seemed like a more severely ill patient population. We had 2 patients who had no follow-up within our system, which we couldn't include. And then of the scans remaining, there were 4 that were unusable because they had anatomical distortion, like subcutaneous emphysema, where all the tissue planes are distorted and you can't do the measurements in those situations. So we had 83 scans for evaluation. We used, again, the CT scan of the chest obtained closest in time to transplant. I developed a standardized image selection protocol where we looked at a single axial slice near the inferior aspect of the T12 or T-bro body. The reference standard, and specifically the oncology literature and elsewhere, is L3, but we don't get L3 on CT scans of the chest. If you are, I think you may need to rethink your radiology protocols. So we can't use it, right? So what do? Well, thoracic researchers have looked at T12, and it's for a kind of an obvious reason. If L3 is your best estimate of total body muscle mass and axial slice there, then the closest you can get to that is probably your best bet. And so the inferior aspect of T12 worked for us. And then we compute the cross-sectional area of tissue looking at Hounsfield units that are consistent with skeletal muscle. And then we did that using Slice-O-Matic software. You take that cross-sectional area and then you divide it by the patient's height in meters squared, so you get a stature-adjusted measurement. And that's called the thoracic skeletal muscle index. And then this is a representative sample of one of our patients' CT scan. You can see the red represents skeletal muscle. And this is done by hand. There are ways to automate this, but because this hasn't been done in this large of a cohort of CF patients, I wanted the measurements to be really precise. Sometimes automated segmentation can include other tissues that also are within that Hounsfield unit range, and so we really wanted to avoid that. So that this was done by hand, and Kathy's nodding because she had to co-review a bunch of these. And it is a labor-intensive process. And then you highlight the skeletal muscle, and then it computes the cross-sectional area. And then, of course, we had the patient's height closest in time to the scan to create the skeletal muscle index. So our primary outcome was post-transplant survival. We also had a few secondary outcomes. We looked at days to extubation, hospital and ICU length of stay after transplant. We updated the survival outcomes as of January of this year. And then we also looked at some measures of pulmonary reserve. I think the folks that I work with in palliative care and oncology were sort of jealous that we have pulmonary function data, right? They don't usually have that on all of their patients, and they wanted to know if there was a relationship between muscle mass and functional status. And again, those values were those obtained closest in time to the CT scan so that they would be more closely linked. We performed a Cox regression looking at the relationship between skeletal muscle index and survival. And this is a small sample size. Even though it's the largest cohort looking at the specific measurement in CF patients, it's still small. So we had to be parsimonious. We couldn't include every potential confounder in the model. But we felt like sex, because of differences in muscle mass across sexes, was very important, as well as calendar year of transplant, because this cohort expanded quite a long period of time, and obviously the standard of care has changed. But we did perform some sensitivity analysis so we could explore those other confounders that people might be concerned about, like genotype and BMI. And then we also looked at, used regression models to look at SMI and our secondary outcomes as well as our functional measures. Because we wanted to really make sure we were doing the data justice, we also did some analysis stratified by sex and then looked at groups based on median SMI. Everybody wanted to know if SMI and BMI correlated, so we looked at that. And then Dr. Ramos helped with our inter-rater reliability measures because, again, we really wanted to make sure what we were doing was an accurate representation of muscle mass. So we had these 83 adults with CF, 45 survivors, 38 decedents over the period of the study cohort. 52% were female, and the median age of transplant was 29. Poor lung function, of course, low 6-minute walk distance. 64% of the patients were Delta F homozygotes, and then the majority of these patients were on supplemental oxygen at rest pre-transplant. I'll give you a little bit of context here because obviously you should know what normal measurements are. I give you the CSA because this is the measure we use for our inter-rater reliability measurement, and you can see that we had an excellent ICC across the two reviewers, which made me feel good about the quality of our measurements. And then median SMI was 25, and of course we saw differences between males and females, which is expected and borne out in other studies of this nature. To give you context, if you look at healthy individuals, a T12 muscle index measurement is around 44 for men and 34 for women. So you can see these, and there's a couple of people who have a significant amount of expertise in this area who are pretty shocked at how low these numbers were. This is quite a bit different than you would expect in a normal healthy person, and certainly even different from other patients with chronic diseases like pulmonary hypertension and other chronic comorbidities. Median BMI was 20, and the correlation between muscle index and BMI was about 0.61, so positive, and it's considered by the correlation coefficient standards a very good relationship, although clearly not perfect. Spoiler alert, there wasn't an association between skeletal muscle index and our outcome of mortality. Neither did we find an association between skeletal muscle index and any of our secondary outcomes. When we broke the groups up into skeletal muscle index groups based on the median values, adjusting for sex, you do see a separation in the line. So people who fall below the SMI median appear to have a lower cumulative survival, but that wasn't statistically significant. And then we did find a significant association, as we had imagined, between skeletal muscle index and pre-transplant FEV1% predicted, wherein the higher your skeletal muscle index, the higher your FEV1% predicted, with a p-value of 0.002. There wasn't a relationship between SMI and 6-minute walk distance, though, not a significant one at least. So to summarize, we were able to successfully quantify skeletal muscle mass in what is a relatively large cohort of patients with advanced CF lung disease undergoing lung transplantation. As I mentioned before, compared to population norms, our patients had a much lower estimates of muscle mass, and we didn't identify a significant association between skeletal muscle index and death following transplant, nor our secondary outcomes of days of extubation or length of stay. There was that association between skeletal muscle index and FEV1% predicted, and again, that positive correlation between muscle index and BMI. I think it's always important to address limitations in any study that you're doing. This was a small sample size at a single center. And even though I have mentioned before that it was relatively large based on the existing literature, we have to take that into consideration. The location of the muscle mass measurement may underestimate total body skeletal muscle. I've already addressed that. We couldn't use L3, we don't have L3, and so we went for the next best approach, which was T12. And then we limited this to people who underwent transplant, so we don't have any ability to give you insights about what the relationship between skeletal muscle index and pre-transplant mortality might be for this group. And then again, this is in the time period before modulator therapy, which a lot of people have spoken about today. So this could be changing. I think the clinical experience has been that BMI does increase when people are on modulator therapy, but there is no real data about what it does to muscle mass. We're still using BMI as this sort of representation of what's happening to somebody's body. But we actually have enough people and enough scans to look at this in a very small group of people on therapy, so we're interested to see what that's going to look like. But again, this is a group of patients from 2018 and before. So what are the implications of this? I think if there had been a very large effect size, we would have seen it. I think you could argue that if we had 1,000 patients, maybe we would have picked up a signal. But then you have to ask, is that clinically relevant? Like, are you going to go through all the trouble of doing these measurements if there's only a small relationship between skeletal muscle index and survival? And then it makes you ask the question, if there really isn't a relationship, why didn't we see it here where we've seen it in cancer patients, liver transplant patients, and all other different types of clinical scenarios? And I wonder if it has something to do with the age of patients with cystic fibrosis, and that despite the fact that you have all these conditions that are sort of relatively chronic, they're chronic over a shorter period of time. So if you think about our adult patients with IPF or COPD, where you have a median age of 55, 65, these patients are younger, and it may be that they're able to rehab better. And so maybe having a low muscle mass before the surgery isn't as impactful as if you're already 65 years old and then undergoing this major operation. It's just a hypothesis. We can't know for sure. It's interesting that we found the relationship between muscle index and FEV1. I think that might suggest some role for muscle index as an indicator of illness severity. So I don't think it's something that you would completely take off the table as something potentially useful in the future, because it did correlate with your lung function. And then lastly, the positive and very strong correlation between BMI and SMI is helpful, but if you remember, the correlation coefficient was 0.61, and that's far from perfect. So I think that they're telling us different things, and the question to be asked is, what is that different thing they're telling us, and does it matter? So if it's telling you something different, that's great, but if it doesn't affect your clinical practice, I don't know that I need to have that information. So I think there's more that we need to learn about this, but at the moment, doing this work, it didn't give me the impression that there's some large association between muscle mass and outcomes, where that needs to be something that's like heavily promoted in pre-transplant risk assessment. I'd really like to acknowledge, first of all, the Cystic Fibrosis Foundation for funding this work. This project came about in my mind related to some work I do in palliative care world, where the oncologists were talking about using muscle mass measurements for enrollment in clinical trials. And so I think that I appreciate the CFF taking a chance on a non-traditional CF researcher to do this work, because I found it really interesting. All the people who helped on this project, and if you have any questions, feel free to @ me at my Twitter handle, and also my bibliography is attached here. And I'd be really happy to answer any questions you all have.
Thank you, wonderful work. Appreciate, there's already several questions, so we might as well go straight to them.
Yeah.
Dr. Nguyen asks, how does change in chest shape, like from advanced lung disease causing barrel chesting, affect measures like the SMI, if we know that? Is there an opportunity to do similar study utilizing whole body composition tests?
Yeah, I think to answer the second part first, I think people have used DEXA scanning, and it's more common in children than adults. We don't routinely do DEXA scans on everyone in the pre-transplant workup. But DEXA scanning also provides you more of assessment of appendicular skeletal muscle. And so I think that these measurements that look at an approximation of total body muscle mass are probably more relevant. In each of these scans that I looked at, obviously there are differences in chest wall, chest deformities. Some people have pectus, and some people have larger chests. I think doing an axial slice and then adjusting it for stature helps to avoid some of the relationship between, the patient is just themselves larger. And that's also the nice thing about using just a single axial slice. There's a lot of interest in other pulmonary populations about looking at a single muscle group, like the psoas or the pectoralis muscles. But as I dove into this line of work, I came across some kind of bee's nest of controversy among radiologists and people who do this about like whether that's appropriate or not. And there are people who have very strong opinions about the fact that you shouldn't use a single muscle group to do this because it's not a good approximation of total body muscle mass. And the measurements can be really unreliable, especially if you're like measuring muscle length across reviewers. And so the party line is that you stick to an axial slice to represent total body muscle mass, but nobody has talked much about like how the shape of someone's chest necessarily affects it. And I think that's because you're using a single axial slice and adjusting for stature.
We have more questions.
Sure.
Going right down the list. Dr. Sagana, did you have access to frailty assessment scores for your cohort? And I'm interested in that because we struggle with this same issue with children.
No, not for this group, but I think that would be interesting because obviously we believe that sarcopenia is a key component of frailty. And so looking at something like the frailty index would be really helpful to relate to these two metrics. I think it may not ultimately be, again, that there's enough of a distribution within the population to show a relationship between frailty and outcomes. If everybody is similarly frail or has similarly low muscle mass, you're not going to see much of a difference, right? And I think that may be why in some studies that look at broad populations of people, you see a difference because you have a 65-year-old man with COPD being compared to like an 18-year-old woman with CF, and that's probably not appropriate. They're not the same type of patient. And so I think having that would be helpful. I think that I kind of wonder sometimes about a composite score where you look at multiple things at once, like a lot of other things we do in medicine, right? You don't titrate the pressors just based on the CVP or the resuscitation. You use multiple metrics. And so you wonder if you could use the frailty index and a measurement of muscle mass and the BMI, because I think it does have some applicability and it's easy to measure, and then use that instead of like picking one thing to put all your eggs in that basket.
Yeah, we're struggling with this because all of them are frail, like you said, and we're trying to use a frailty score that's being modified because nothing exists for children, and we're using that test on kids that are walking around our unit on ECMO. So it's a different situation. We have more questions, so I'm going to throw this out here. Dr. Jelm has asked the question: is there a T12 SMI to define sarcopenia, or is there a threshold that is concerning for impairment?
Probably not for T12. There are for L3 because it's just so much more commonly used. Again, there was a relatively recent systematic review in oncology patients, with over 5,000 participants. So they have a lot of more data about this, and so they do have cutoffs. A lot of people, what they do is they create a cutoff within their own population because it's so hard to compare across different disease states. I think the reason we pulled out the measurements from a paper where they looked at healthy individuals is just give people some context. Even though we don't have a cutoff for this value, all of these patients would be, by most standards, would be considered severely sarcopenic. So it was hard to say, like, you're a little more sarcopenic than this person. And that may be why, again, we didn't see a relationship because they're already all so sarcopenic that you're not going to see that because there's not a great distribution across the variable.
Dr. Turner asked, have you considered looking at pre- and post-transplant SMI in relation to post-transplant outcomes, i.e. change in SMI positively makes them more likely to survive, et cetera?
So we didn't look at post-transplant muscle index, and I think that would be interesting. Another thing that's some people have a question about is looking at adipose tissue, because in other disease states, higher degrees of adipose tissue are associated with worse outcomes. But we didn't specifically look at post-transplant muscle index, but I think that would be valuable. And also incorporating measures of actual muscle function. So, I mean, this is an image, right? This is a picture of somebody's muscle. It doesn't tell me necessarily how well that muscle functions. And so I think that would be valuable. And then regarding the fat mass, one of our thoracic radiologists, he kind of like chuckled when I asked about it, and he said, "What fat?" He's like, it was hard enough to measure the muscle in these patients. There is no subcutaneous fat. And so you're not talking about people who are, 65 years old with atherosclerosis and COPD who have a ton of mesenteric and mediastinal fat. These patients barely have much muscle to highlight, much less fat.
Any more questions?
Let's have a thought about it. So the people who have the tumor SMI, they also have the, I don't know if you have access to the, they've been treated with the PEG or some replacement therapy clinically. But sometimes when we have low BMI, we try to push for I had a girl recently, we were trying to push for BMI, and it was 14. I don't know what the threshold is, some people say 18, 16.
Yeah.
We were up to 18, so at some point we tried to have everything. But we never looked at the SMI, so you had a big data and a live for 30 years. If you go back, I don't know if you already have it, how many of those were on peg group? And the idea that they have a repeated SMI that the peg group translated into improved SMI.
Yeah, I don't have like a pre and post initiation of tube feeds. There were several patients in the cohort who had feeding tubes, obviously, because at first I was debating whether to include them because the feeding tube actually affects the anatomical, it does create some distortion in the tissue planes, but actually where the peg tube is usually placed, it's fine. And so I included those patients. So there weren't many, but I think that would be really interesting to look at pre and post, because the assertion is if you improve someone's nutrition, you should be improving their muscle mass and then hopefully their ultimate outcomes. But we didn't exclude anybody based on the fact that they needed a feeding tube. But I'd have to go back and look and see if there was actually a difference based on that. There weren't many people, so it'd probably be hard to detect that. But that would be also interesting to look at.
We got all kinds of questions.
Have you looked at healthy patients with CF and their SMI, and are they lower than the average population versus the same counterparts?
No, I mean, and then sort of a point to Dr. Chaudhry's comment that is important to make in terms of this population. These were all people who underwent transplant. So especially at our institution, you're already selecting out for people who are like extremely underweight because, every center has different sort of thoughts about transplanting very underweight patients. And so it'd be interesting to look at people who are, so too thin to be referred for transplant and see if you can improve their skeletal muscle mass. And then to your point, in the patients who are healthier and may not meet criteria for referral, if they have sarcopenia as well. If I had to guess, I'd probably say yes to some degree, but probably not as extreme as these patients. I would have to guess they're probably not anywhere close to population norms because you saw here, I mean, that was like a 20-point difference between a healthy male and a male who's like awaiting transplant with CF. I'm interested though, even though it's like a tiny group of people who have been on modulary therapy long enough and have scans that were already done, to look and see if their pre and post modulator scans show that, because I think people see the increase in weight, but we don't really know if that correlates to like sort of healthy weight gain or if it's just fat. Yeah.
Actually, wanted to add to that, because our center had done a study recently at Cincinnati Children's using bioelectrical impedance analysis on pre and post modulator therapy.
Oh, yeah.
They pretty much have all that gain. There was no like change in muscle mass among the studies. So there's a postcard for Carolyn.
Yeah, I think that's really interesting because you would assume, right, like, oh, if you're healthier and you're not having as much difficulty with respiratory infections and your work of breathing, that your muscle mass would improve, but you still wonder, despite the positive changes from the modulator therapy, if there's still such a catabolic state that you can't accrue muscle mass, and it's much easier to accrue fat than muscle mass, unfortunately, and so it's hard for people to gain muscle mass, especially without a lot of intention directing at it.
Yeah. I've experienced that with gray hair.
Yeah,
As that evolves, there's
all sorts of always the negative thing is easy.
There's a direct correlation there. Any more questions? Oh, we got one over here.
Kind of a question and a comment. So I am one of the pulmonary fellows in Florida, and so I work predominantly in like an adult population, so transplant. I will say that a lot of our older patients, so the ones that have CSC, IPF, that do get transplanted, yes, there are some of them who are underweight, and so there's an effort to go and like have that put on weight so they're in that healthy criteria. But the ones that are overweight, there's also a push to go and get them into like a regular BMI, kind of whatever that's going to be, or closer to normal, because there's a concern that their abdominal adiposity is going to provide increased like intrathoracic pressure and cause them to have more atelectasis once they get transplanted. I do think your presentation is particularly interesting because you're right. It's very hard to go and say that the person who has IPF, which for most of them, the COPD is kind of like a longer term process. They've had it for like years and years and years. But IPF oftentimes is like a shorter onset, and so they don't have some of that like
maladaptive, like muscle loss that develops with it. So I do think your question is really interesting, is that, can we do kind of muscle, like assessment to go and see if somebody is fit? I guess my second question, which would be interesting to ask, is in somebody who was considered to be transplant eligible, so they had a loss in their FEV1, they were newly on oxygen, either from a pediatric, like from the CF side, or from like an adult condition, so COPD, IVF, if they actually went through the 14 weeks of like rehab that is oftentimes recommended to get people to a full weight, or to get people to like a full function, to say that they're now fit for transplant to address their deconditioning, does their muscle mass improve, like from a 20 and 22, your SMI, does it improve from that to something higher? And does that correspond to like improved outcomes?
Yeah, I don't know. I mean, I think that there are two concepts that are important to bring up. There's one that's the concept of sarcopenic obesity. And so this is something that's not as germane to the CF population, but the oncologists who work on this topic talk about is that they have patients who are obese by BMI criteria, but they have no muscle mass. And so often those patients are restricted out of some clinical trials because of their weight, because of how heavy they are, but a lot of that is fat and not muscle mass, and a lot of the drugs they're trying to use are directed towards nutrition and to inhibit the catabolic state, and so it really affects their research. So in adults with other disease conditions, I think sarcopenic obesity is a real issue. And I think we know from like adult COPD literature that doing pulmonary rehab has benefits, especially in terms of muscle function, but I don't know if we know if it actually increases muscle mass. And I don't think those are always necessarily the same thing, because you can increase your function without necessarily accruing a lot more mass. And if I had to guess, I would say that you wouldn't see in those patients a significant increase in the muscle mass, maybe to some degree, but not significantly, but you can see improvement in muscle function. But I think, again, it sort of brings back to that more holistic idea of using several different parameters instead of just picking one, like muscle index versus frailty versus function. Like it probably should be incorporated into a multi-component score to give you a more global assessment of somebody, because each one of these in isolation may not tell you very much.